Good afternoon, everyone, and welcome to the PHSSR Research in Progress series, Bridging Health and Healthcare. This is Angie Carmen. I'll be your moderator for today. Our topic is cross-sector collaboration between local public health and healthcare for obesity prevention. Our presenters are Dr. Katherine Stamatakis and Dr. Eduardo Simoes. Dr. Stamatakis is an associate professor at the St. Louis University College for Public Health and Social Justice. In addition to leading a prior RWJ-funded study in PHSSR, she has conducted recent work on assessing the influence of community health improvement planning on prioritizing obesity prevention in the U.S. local health departments and describing local models of practice in obesity prevention from the perspective of state program directors. And also, Dr. Simoes is the Chair and Alumni Distinguished Professor of the Department of Health Management and Informatics at the University of Missouri School of Medicine. His work in public health includes development of prevention programs, surveillance systems, public health prioritization models, and the evaluation of public health interventions. We will proceed with the presentation, during which I would encourage everyone to mute their computer speakers. After the presenters have completed, we will introduce those individuals who will be providing commentary for us today, and we encourage all of you that are on the line to put your questions in the chat box, or we will open the phone lines for your question after the commentators have provided their input. So, Dr. Stamatakis, I'll turn the program over to you.
Thank you, Angie, and good afternoon, everyone, and good morning to our colleagues out west. I'm happy to be online with you today, along with my colleague and co-PI Eduardo Simoes and other members of the research team, give you an overview of our project on cross-sector collaboration around obesity prevention. I'll be presenting most of the talk today, and then at the end we'll turn things over to Eduardo so he can provide some additional thoughts. Our special thanks goes out to Belinda Heinrichs and Rebecca Lobb, who will provide commentary from both practice and research perspectives following this talk. We are currently in the midst of data collection, so this is a true works in progress, and please be advised that any findings today are very preliminary. This project is supported by a Public Health Services and Systems research grant through the Robert Wood Johnson Foundation. And we would also like to acknowledge and thank the National Coordinating Center for PHSSR for providing assistance with the project and organizing the webinar today. This research would not be possible without the support of the various local and state health departments across the U.S. who have participated in our study, and we thank them as well as our practice-based advisory team for their advice and feedback throughout the project. So other members of the academic research team include Rebecca Lobb, Anna White, and Elise Meyer, our talented program manager, project manager rather, who ran all the analyses I'm showing you today. As well as our practice-based advisory team, who I just mentioned, which includes Stephanie Browning, Susan Coons, Deborah Markinson, and Kathleen Wojciechowski. As background to the study, I just want to briefly touch on some main points that guided our approach. So the first is that locally oriented prevention efforts are needed for obesity prevention, especially regarding policy and built environment interventions. And cultivating partnerships with other community health stakeholders is key for successful implementation. Furthermore, the implementation challenge at the local level, particularly given the large degree of variability in funding structures, areas of programmatic focus, and capacity among local health departments, may be overcome in part by strengthening linkages, in particular those between public health and healthcare. And this may have a variety of results, including sharing data and methods for conducting community health assessment, fostering local advocates or champions, and ensuring the orientation of efforts toward reducing disparities in underserved populations. As part of a previous study that laid some of the groundwork for the current study, practitioner perspectives indicated that local leadership on community health assessment and improvement planning was centrally important for prioritizing community efforts in obesity prevention. And with the Affordable Care Act and other prominent calls to integrate public health and primary care, the structure of healthcare delivery is likely to undergo significant changes in coming years, with increasing attention to primary prevention of common causes of chronic disease. Furthermore, the ACA requirements for joint health assessment provide a leverage point and opportunity to bring healthcare and public health sectors together around community needs and health priorities. So our approach for this study was framed by the opportunity of joint community health assessment through shared efforts between local health departments and local healthcare partners, including nonprofit hospitals and community clinics like FQHCs, to serve as a leverage point for further enhancing collaborative relationships. So the central piece of the study design is based on a framework developed by Frey, Lohmeyer, and Tollefson, published in 2006, to describe levels of collaboration, beginning with loosely defined networks and advancing through subsequent stages to cooperation, coordination, and coalition before ultimately reaching full collaboration. So we based measurement components in the study around the model pictured here, with the plan to examine how the extent of collaboration may influence collaborative arrangements and, in turn, the types of activities that are implemented in obesity prevention. And we also hypothesized that there are other contextual characteristics that could influence this process, including trust among partners and other local barriers and facilitators to cross-sector collaboration. So the study was organized around two main aims. First, to develop instruments to capture the level of collaboration and related shared practices between local public health and healthcare organizations in obesity prevention. And so this includes both a questionnaire and abstraction tool development. The second aim was to collect and analyze data from a national sample of selected localities where surveys are being administered to the local health department as well as to their hospital and community clinic partners who are identified by the local health department respondent. Our survey development began with a literature review where we ultimately set the search criteria to focus on existing measures and theoretical models that described levels of collaboration on a continuum. We decided on the Frey framework based on its development in theory and its adaptability to be tested as a single response item measure or a composite measure based on multiple responses, and I'll describe that in more detail a little further on. The next steps involved crafting new items or revising items for other components of the questionnaire, then conducting an initial review of the survey with the advisory team, and finally pilot testing and revising based on feedback from respondents in the field. The abstraction tool, which I'll just describe briefly, was developed based on survey components but simplified. And then it went through several rounds of revision and pilot testing with sample planning documents. We are now collecting plan documents from survey respondents and have started coding using the abstraction tool, which is being done independently by 2 members of the study team. So to carry out the measurement study, we'll be looking at a number of things. We'll be first examining test-retest reliability of the survey measures, as well as face and construct validity and reciprocity in terms of agreement of measures among partners within each locality. With respect to the abstraction tool, we'll look at inter-rater reliability and agreement with similar items on the survey. So to some extent, albeit limited, this will be making a self-report versus objectively documented comparison. And so here's just a bit about the status of the survey, which for the purpose of these preliminary analyses presented today, we put a lid on last week as far as the data that we were looking at. But hopefully data collection is occurring as we speak. We have used essentially a 2-step screening process to determine an eligible pool for the study. So first, the previous survey that I mentioned served as an initial screener to identify LHD participants that had reported collaborating on joint community health assessment with a healthcare partner. And so this was based on, obviously, the idea that we could only study characteristics of collaborations among those that had already established some linkages. So out of the 150 responses, we've identified 113 LHDs who conducted a joint health assessment and improvement planning process with healthcare partners in the last 3 years. And to date, we've received 36 surveys from LHDs, as well as a handful from hospital and other partners. And as I said, data collection is ongoing. So on the following slides, I'll walk you through some preliminary results from the study with, again, the emphasis on preliminary. So at this point, I'd like to ask you to please not focus so much on the numbers as on the measures themselves, as these data are subject to change as we continue data collection over the next several weeks. The next couple tables I'll show you illustrate some sample characteristics that we are collecting. These tables include only LHD respondents at this point. So you can see the number of respondents is 36, as I mentioned. I'd also like to mention that we are using a stratified sampling scheme by jurisdiction size to give us the ability to look at collaborations in rural as well as more populated areas. We hope to have roughly equal numbers in these 3 groups by the end of data collection. So the plan is to have 60 in each group for a total sample size of 180, including LHD, hospital, and clinic partners. As far as governance type, common is local, and the vast majority of respondents reported having healthcare partners that existed before the ACA was implemented, which reflects the screening criteria I mentioned before. We also asked LHD respondents to give us a little more information about the experience of working jointly on health assessment and planning with both hospital and clinic partners. The vast majority of LHDs indicated that this joint process strengthened an existing partnership, especially with their hospital partner. And most also reported being satisfied or very satisfied with that joint health assessment planning process. The responses regarding clinic partners were similar, although we're seeing a little more variability there. We also asked LHDs to tell us at what point along the continuum of levels of collaboration they would place themselves with respect to hospital and clinic partners. And so far, most are falling somewhere around the middle of the continuum, with the fewest in the earliest kind of networking stage, and with responses for hospitals seeming to tend toward higher levels of collaboration than those with clinic partners. In addition to indicating to us where the collaboration fell along the continuum, which is illustrated in more detail here, we then collected responses on a 5-point Likert scale for every item comprising each level of collaboration construct. So for coordination, the construct that falls in the middle of the continuum that you see here, we had 4 items for sharing information, defined roles, frequent communication, and some shared decision-making. And under each level, you can see that the level-specific average score from our preliminary data so far seem to roughly follow the pattern from the overall continuum response on the previous slide, which gives us some preliminary sense of face validity, perhaps. So another important factor for us to measure was partnership trust. And for these items, we used a partnership trust tool that was adapted from one created by the CDC Prevention Research Center, which had been previously research tested. The partnership trust tool asked about partnerships as a whole for all partners. And the mean scores shown here are for the response to how often the trait occurs in the partnership. This tool also includes scales for the importance of each trait, though those we looked at, and they're generally topping out at the high end of the scale, so there's less variability there to report. So here there are 12 items that you see. The highest score is for providing accurate information, and the lowest is for sharing power and responsibilities, which is similar to an item from the collaboration measures that also scored on the lower side, although those results weren't shown here. Okay. So another component of the questionnaire includes measures of community context around collaboration. There were a number of factors that were measured to capture contextual characteristics around the collaboration and in the community. And these were adapted from items of the Wilder Collaboration Factor Inventory, which has published reliability measures on the original instrument. So the characteristics shown on this side are the ones that have so far come to the top in terms of the frequency of affirmative responses. And these include things like recognition that the effort would be difficult for a single organization to carry out, that the leaders have skills conducive to collaborating, that the collaboration includes appropriate stakeholders, that there's a history of agencies in the community working together, and that reasonable goals are set by members of the collaborative group. And just to provide some contrast, the contextual factors that we're not showing all of them here because it's a long list, but the ones on this next slide are the ones that are so far ranking at the bottom of the list in terms of affirmative response. And these include having a supportive political and social climate, the ability to survive change, having a clear sense of roles and responsibilities, working at the right pace, and having a clear decision-making process among partners. And just note that the percentages here are still in the 60s, so these shouldn't be considered unimportant. And we think having some variability in the responses to these contextual characteristics should help subsequent analyses with teasing apart the ones that most closely are related to higher levels of collaboration. The last component of the survey includes questions regarding the types of obesity prevention activities being implemented and the types of collaborative arrangements around them. So the items for measuring implementation of obesity prevention were based on groupings of interventions that address policy, built environment, and health education campaigns for healthy eating and physical activity, which were derived from evidence reviews and consensus documents from expert panels. On the online survey, each of these items also had rollover boxes that would pop up to provide brief examples to help further define the types of interventions for the respondents. And on the LHD survey, the LHD respondents were asked to respond whether they served in a leadership or collaborator role for each item. And those are the percentages that you see here. So as we expected, LHDs appear to more commonly serve in a collaborative role overall as far as implementing obesity prevention interventions, both those that address policy and changes to the built environment, as well as those that are focused on raising awareness or health education type interventions. However, a substantial proportion have reported taking a lead role, which was interesting to see, particularly with respect to policies that encourage physical activity in community settings and community-wide health education campaigns to increase healthy food choices. And lastly, we have our section on collaborative arrangements. So for any specific intervention that respondents indicated, they were then asked whether they had a collaborative arrangement around implementation, which included things listed here: referral, co-location, purchase of services, serving in the role of a backbone organization in a collaborative, and working on joint advocacy activities. So what you see presented here are percentages, the range of percentages across those items that you saw on the previous slide. It was busy to show it all here. But so far, the most common collaborative arrangements across intervention type are advocacy, serving as the backbone organization, and referrals. So finally, next steps of the study include collecting retest data for the reliability study, abstracting data from the planning documents, and expanding the survey to healthcare partners identified by the LHD respondents. We foresee having to start making phone calls to try and up our response rate in these areas. As far as analyses, in addition to the measurement study analyses, we also hope to gain some understanding of organizational, partnership, and contextual characteristics that are most strongly related to levels of collaboration, and in turn, how level of collaboration predicts collaborative arrangements and implemented programs and activities in obesity prevention. So these research questions are all guided by that study framework that I showed on one of the earlier slides in the figure. Our results will be disseminated to study participants and other stakeholders with the guidance of our advisory team, and we hope to collect feedback about the report from respondents. This should be taking place late summer, and in the future, we hope that this tool may be able to be used in the context of a natural experiment or to test an implementation strategy in order to measure change in level of collaboration as a function of some intervention or policy change. We also hope to expand the sample to be able to obtain more rigorous effect estimates for how various components interrelate, again going back to that framework. And finally, a larger sample size would also allow us to conduct more rigorous psychometric testing of the survey instrument, in particular confirmatory factor analysis of the items underlying the measures of collaboration levels. So, and those again are all future plans. This brings us to the end of my talk, and I'd like to turn things over to Dr. Eduardo Simoes if he has anything to add here at the end.
Thank you, Katie. I'd just like to add a few points. First and foremost, you've done an excellent job in making the presentation so easy to follow. There will be some questions. I just read a few questions for you have to address soon. But second is the fact that for those present in this webinar, that we didn't have any clear expectation starting this research. It's just the hope that this line of research will be very instrumental in the near future for true collaboration between healthcare and public health practice. Sitting on as a chair of the Department of Health Management and Informatics and going to conferences and meeting with people over the past 3.5 years that I only tangentially met over the past 20 years in public health, had given a completely different perspective and the understanding how important this type of research is. And I know it's going to resonate with what Chris is doing and some of you in the presentation are doing right now. I just came yesterday from the American College of Healthcare Executives. I stayed there for 3.5 days in Chicago. And the distance between what they consider to be important and what we consider to be important, it's still humongous, still huge. And at the same time, they're making presentation and showing that they do not control the behavior of 65% of the population they serve that's causing them most of the cost. So it's pretty obvious that this is a clear area for prevention, but how can they not see that? And what do I mean by that? If you have 65% of your hospital population indigent and causing incredible cost to your system and difficult in demonstrating to the federal government, your main payer, or the state-based Medicaid program, that you're making a difference for the lives of these people, why don't you partner with public health? So these are my questions to them, and they're beginning to see some important points there, but they don't have the tools, they don't have the monitoring system, and they don't believe we can present a case that these collaborations are actually making an effort. There's one thing about presenting, in a forum and among public health folks and say, we're making a difference, we've seen this, and this is it. But more important, we need to make these presentations to that crowd over there. We need to bring that research to them that they can see that through perhaps a community health assessment that's now mandated by law since 2010, that's the Patient Protection and Affordable Care Act, Section 9007, that this can go beyond. It can be used to address those issues. So that's the impetus for this type of research. It's really a larger policy issue that people can't see it. But as we develop tools like that and be able to monitor and measure these collaborations, show some example where the collaboration needs to go. For example, right now, as you see in the last slide of results, what we like to see is more what I call true collaborations reflected by people exchanging resources. And even though our sample size so far is very small, very few are doing purchase of service, co-locations, and to some extent, the backbone organization. Most of them are on the advocate, collaborate, and advocacy for intervention. That may be the prevailing result in the end. So that means, together with the information we're providing on implementation as well as the modified FRAE model of collaboration, you give us a perspective that we can publish and bring a discussion, bring forward with the healthcare providers to understand that we can make an impact in prevention and reduce the cost and make their margins better by reducing their cost through effective prevention. So that's the genesis of what we're trying to do in this type of research. And there will be more, and I'm sure many of you have questions. So, talk too much already. Okay, you have a few questions there already at the bottom. We do.
We'll go ahead and turn the presentation over to the commentators, and after they have had the opportunity to share some insights, we'll take the questions both from the chat box and open the phone lines. So we will move to Dr. Rebecca Lobb, who's the Assistant Professor in the Department for Public Health Sciences at Washington University in St. Louis. Dr. Lobb, would you like to provide some comments now?
Thanks so much, yes, and thanks, Katie, for sharing your progress on this important project, and Eduardo for those comments about the relationships that exist now between healthcare and public health. There's a growing need in practice and in research to develop strong instruments that assess collaboration among organizations to improve health. And this project is a great example of research that's filling that gap. This increased need and interest in measuring collaboration has largely been driven by implementation of the Affordable Care Act. Katie mentioned that nonprofit hospitals are now required to conduct regular community health needs assessment with input from public health units in order to maintain their nonprofit status. But payment models are another way that the Affordable Care Act is encouraging healthcare organizations to collaborate with public health units or other organizations. These payment models, like accountable care organizations or bundled payment arrangements, are designed to make healthcare less expensive, more efficient, more focused on the provision of preventive services and better quality for all patients. The Department of Health and Human Services has high expectations that these payment models will become the norm for reimbursing healthcare organizations. They've set a goal of tying 30% of fee-for-service Medicare payments to value by the end of 2016 and tying 50% of payments to these models by the end of 2018. The Department of Health and Human Services is also actively encouraging other payers to do the same. So these new value-based payment models will require healthcare organizations to collaborate in order to improve efficiency in transitions of care from primary care to specialty care or from hospital settings to community settings, to reduce unnecessary variability in clinical outcomes and to improve patients' experience. As a result of these changes in the healthcare landscape, it's likely that interest in measuring collaboration will grow because organizational leaders and program implementers will want to identify opportunities to advance a relationship with other organizations, and they'll want to assess changes in their level of collaboration that come about from working together to assess and improve population health. The project we heard about today fills a need to develop strong measures of organizational collaboration on goals to improve health. Strong measures are considered valid and reliable. Valid measures assess what they're supposed to assess with minimal measurement noise due to misinterpretation of the meaning of the question, missing data, or response bias where participants tell us what they think they want us to hear. Reliable measures are consistent. They provide the same result in similar circumstances, so you have a high degree of confidence that differences in measures across respondents or over time are due to factors other than error in measurement. Among the strengths of this project is that it's using a measure of collaboration that demonstrated strong validity and reliability when tested in a school-based setting. By testing the instrument in a healthcare setting, and public health setting, this project improves the portability of the instrument for use in measuring collaboration between healthcare organizations and public health units. Also, the FRAY instrument that the research team started with was based on theories of collaboration. Using a measure based on a theoretical framework or model guides the content of the measures and can help researchers and program implementers interpret the results for practical applications. Another exciting feature of this study is that it's powered to examine properties of collaboration for public health units and in urban and rural settings. And this is important to research as well as practice because we know that public health units operate differently in these types of settings. By testing the validity and reliability of the collaboration measure in both rural and urban settings, we'll know whether any differences in collaboration by size of the jurisdiction can be attributed to true differences or a weakness in the measure. So there is an increasing pressure on healthcare organizations to transition from providers of sick care to providers engaged in improving population health. And this transition requires that healthcare organizations work across the silos of care that were built on a fee-for-service payment model and move toward integrated care in collaboration where patients are supported by a single system that enables quicker recoveries, fewer readmissions, lower infection rates, and fewer medical errors. And this project brings us closer to actually being able to assess how the level of collaboration between organizations is associated with potential improvements to population health.
Thank you, Dr. Law. Did you have additional comments that you wanted to share?
I don't.
Okay, thank you. We'll turn the presentation now over to Belinda Heimericks. She is an administrator in the Section for Community Health and Chronic Disease Prevention in the Missouri Department of Health and Senior Services. So Belinda, would you like to share with us?
Yes, and I want to thank you very much for inviting me to be part of this webinar. It's a very important topic, and I thank Katie and Eduardo for the work that they're doing on this study and this particular project. I think it's going to be very beneficial, and I can only speak from my experience in my role with the State Health Department as we have worked on collaboration with a variety of partners. And I see some wonderful opportunities as a result of the changes that require hospitals to perform the community health assessments. And I see challenges as well for the local health departments as they move into this new relationship, this transition that Rebecca had just spoken about too. I do see it as a transition. It's a shift for the local health departments and the area hospitals to begin working together so that they can collaborate and form those stronger collaborative relationships. And what I have seen is that hospitals have not been engaging the local health departments at the rate that we think really should be beneficial and should be occurring. And so I think this project will help us identify ways that we can strengthen those relationships between the health departments and the hospitals. I think another challenge that I'm seeing is that the local health departments have experienced such a downsizing of their staff and financial resources over the past years that their infrastructure needs to be rebuilt, if you will, or strengthened so that they can engage to address some of these issues related to addressing the issue around obesity, which we know is a serious epidemic in our nation right now. So with that in mind, I think we're truly in a position to move forward. I was pleased to see that so many of the survey respondents at this point had really addressed the issue or acknowledged that they were in the area of, I'm looking for my notes right now, excuse me for just a minute, that they're as high as they see themselves in coordination as far as that partnership development. And so it's exciting to see as they build that trust relationship amongst themselves and transition through these different levels that they're moving towards the collaboration role. So I think the health departments, Eduardo, Katie, others who are on this team and participating in this webinar are all in a position to help the hospitals and the local health departments strengthen those relationships as we move forward. And as we do that, I think we'll be in the position to be able to provide our resources to help them move forward in developing evidence-based interventions that will help address the issue of obesity within the state. And so those are my comments at this time.
Thank you, Belinda. We appreciate that. We will move to the chat box now. We have a couple of questions. The first question says, you said out of 150 responses, 113 or 75% conducted a joint community health assessment, community health improvement plan with a healthcare partner. The question says, my computer lost connection with the webinar while you explained this slide. How did you decide who to send this survey to? 75% seems like a high level of joint community health assessment, community health needs assessment. So could our presenters respond to that question, please?
Yes, sure. This is Katie, and thank you for that question. It's we can go back to I think this speaks to our selection criteria for the survey. So and that was probably right when your connection left off, when I was talking about starting with a pool that we had identified from previous work who had indicated that they had some collaboration with healthcare partners around health assessment. And we started with that pool because we wanted to be able to capture measures of characteristics of the collaboration. So we wanted to pull people in that had a collaboration and start from a smaller pool, knowing how much work it takes to get respondents for a survey like this. So that is likely why you see such a high percentage there.
Thank you. We have another question that says, would you talk a little bit more about referrals?
Yes, sure. So I will, I'll tell you a little bit more about what that item measure was, and maybe turn it over to Eduardo then, who was really, this was the brainchild of Eduardo, this section of the survey. So the referral arrangement was defined as one organization refers its clients to the other organization for services. Eduardo, did you want to make any additional comment about referrals?
Yes, I would like to. For example, which is going to be a small percentage of the pool, hopefully in the end, we can clarify that or not. But at this point, based on my just prior experience in visiting hospital systems in the state of Missouri, hospital, for instance, refer patients for preventive service. In a few local public health agencies, they still do the bulk of the preventive service, like vaccination. On the upside, you can also have local public health agencies referring clients, so to speak, that came for some service they cannot offer, but they know the local hospital or the county hospital or the private hospital, it's offering that for a reasonable, cost or no barrier at all. So that's the type of referral we're talking about most often. It will be more important later once you have the final data to create an expectation, which is easy to create by going back to the local public health agencies, and we can find out it's listed whether they offer those preventive service or not, if you're looking for referral from the one sector to the other. And vice versa, most hospitals do have, and hospital system in this case, or clinics, have some form of preventive service that they offer, either screening or vaccination and so on and so forth. So we can create an a priori expectation and compare our results with that expectation. What should have been the referral? And as you can see, this is based on a lot of practical stuff that we do. I think in the end, we'll see how it's going to work, because we should have co-location, purchase of service. These are a strong form of collaboration, especially purchase of service. So I'm going beyond that. But that's what we're trying to capture a little bit here. It hasn't been done before, so it's new stuff. You can learn a great deal. Have to wait and see what's going to happen.
Thank you. We've got another question. Do any of your measurement strategies get at the sustainability of the collaborations?
Well, this is Katie again. I think that's a great question. And so I think the answer is not directly, but that there may be some components here that could reflect some aspects of sustainability. So I'm thinking of some of the collaborative arrangements that Eduardo was just speaking about. For example, some really require strong commitments that may speak to sustainability. But I would be interested in thinking through how some aspects of sustainability might overlay with some of our measures, with those of you like Dr. Malon who have given a good deal of thought to how to conceptualize and measure sustainability.
Katie, just to make the point, I'll give an example. I don't know if they still do that, but Duke University Hospital System, for many, many years, they purchased service from many local public health organizations. And they, through that purchase, they established a very strong relationship and has been sustainable for over 10 years. At that point, I was talking to them about 3.5 years ago. So there are indications from many of the different tools that we have here that if you have those things present, likely are going to be sustainable because there's a higher level of commitment. Every time you purchase service and you develop some kind of a compact or a memorandum of agreement or contract, this is a strong form of collaboration and sustainability.
Thank you. Another question, what specifically can rural community health workers do to move this forward?
Wow, well that's a great question. My first response to that is if you get our survey, please respond to it.
Katie, this is Belinda. Could I speak to that and what is happening
Yes.
in Missouri? Okay. I know that different states are implementing or promoting the use of community health workers in different ways. One of the projects that Missouri has started we are involving our Medicaid program, MoHealthNet, and we are working with the local health departments, and so it's part of the Medicaid Health Home Project in which they're identifying their high-end users of Medicaid, and we're trying to get them into health homes. Where Missouri, the Department of Health and Senior Services, is also working through contract in developing a standardized curriculum for community health workers. And our goal, as we collaborate with the Medicaid program and the local health departments and also the Department of Mental Health, is to be able to place the community health workers in the local health departments so that they can then work within the communities to help the individuals in the communities become more knowledgeable about the various resources. So we're looking at them, using them from a standpoint of community clinical linkages. And so we're working on how we can fund that type of a project then. But that's what we're doing with community health workers and our local health departments.
Thank you, Belinda. Back to the issue of referrals, the question says, would you include referring to education programs, for example, diabetes prevention for at-risk populations?
Oh, absolutely. Let me just give another angle of these questions on collaboration. We didn't want to set the responder to be thinking about any specifics, because this is the first time we've been asking in conjunction with the other components of the surveys, like the modified frame model, the trust, and all these issues. So we wanted to be very freewheeling for the person to answer, but it's clearly this is part of it. What I would like to do at the very end with Katie is to identify if you have enough of referral, enough of collocation, and to do case studies on those to understand. For instance, in visiting San Diego, I think it's south of San Diego, I forgot the little town on the border of Mexico, they have a program that they copy from a program that Prevention Research Center at CDC created way back in Brazil, northeast of Brazil. So they copied the model that program to the local public health agencies. And they have patients, members, participants of this physical activity program, and they screen them, and once they identify they have a problem, they had to create a memorandum of agreement with a local hospital or public health agency to refer the individual who have high risk for obesity and diabetes and things of that nature. So I didn't want it to have any preconceived example there so people say, oh, only those would apply. I want them to be open when they say referral. The word says one organization refer its clients to the other organization for services. And I want them to be really open-minded, hopefully, and that can give us enough numbers that so we can do case studies to really understand what's going on here. But this also applies, absolutely.
Yeah, and I'd just like to add that we have some open-ended questions at the end of this section where our participants are really taking a great deal of time, many of them, to give us a lot of detail about what these collaborative arrangements look like. So that'll give us a little bit of a jump start on the case studies. And we've just, it's a lot to read. We're really so grateful to our respondents for giving us so much detail on that section. And you know, we've just started looking at it, but we can see that that we've got some good information there that we'll have to analyze.
Thank you. I don't see any more questions in the chat box at this moment. If anyone has one, please go ahead and put it in. But we will open the phone lines if anyone would like to ask a question of our presenters or our commentators today. I think we have another question coming in. I noticed during the presentation that you talked about looking at collaboration with hospitals and also with FQHCs. Are you thinking about looking at other collaborative partners that may be at the table with regard to obesity prevention, such as county extension agents through agriculture connections, farm-to-school programs, that sort of thing?
Well, that's a great question, and I think for the purpose of this study, and we had conversations about that early on as far as how far to extend this into these collaborations, and we made a decision for this particular study to focus more just on the healthcare partners, but some of our respondents are actually giving us contacts in other organizations in the community, so we may at some point be able to start looking at that, although the way the study is designed, it's not to collect information from, you know, really across the breadth of the whole collaborative.
Yeah, it's almost like the sampling design basically constrains that, you know, to focus more on the healthcare. As you remember, the 150 and the 75% of them are collaborating in some form or another in healthcare type of collaboration with community health assessment. So that's the premise of the research. It's kind of a preclude us to extend it too much, but there are a few they are mentioning. There's open open-ended question that they have added some element that we'll be able to explore that too in the future.
Okay. Looks like we have a couple more questions. One person asked, can you provide a list of the 36 organizations who responded?
We assure all our respondents that their information is going to be kept confidential, so we don't have any plans to share the list.
Another question is, have you thought about partnering with health insurance payers?
No, I don't. That hasn't really entered into our discussions.
I'm sure they'll be interested in that information once we have something to present and open forums and present to the to the healthcare group. But insurance payers are becoming more and more a big player right now. They are reorganizing the healthcare system to attend to the needs of ACA, and payers, for instance, the University of Missouri, they're creating their own product, their own insurance products right now. So the payer is becoming a very, very important player, and they are modifying the healthcare delivery because of that, and they are making efforts in prevention because of that. So there will certainly be an important group that we need to consider involving it, in the long run. If this type of research continues, which I hope we will for many years to come.
Just a couple more questions. We have one that says, in our rural community, we only have one small hospital. We have reached out to surrounding hospitals and feel like we're at a standstill. Do you have any other ideas?
I don't know that I could speak to helping you reach out to other hospitals, but this is really, I think this speaks so well to why we are trying to stratify our sample and capture some collaborations in rural areas as well as more populated areas, because the idea that we had was that the way collaborations might occur could be very different depending on geographic area.
And one of our listeners says, we currently have a collaborative to create a single community health needs assessment with local public health, hospitals, and payers who are all required to respond to the needs of the community, which is where the question came from about the insurance payers and other partners.
Yeah, well, I think this is part of the reason we're trying to do this type of research. We need more information to guide us on how to go about these things. If you look historically, many hospitals and healthcare systems have done community health assessment in the past in collaboration, but it was more like a token, the collaboration. It's really to implement and to look good to the community, to have buy-in politically and have marketing strategy. It was not really meaning to make a difference. What is happening now is that because they have to demonstrate the metrics, like Dr. Loeb shows us in her wonderful synthesis of the issues that I just, tangentially touched early on, that they need to actually be about prevention in a more effective ways. And what a better way than do a true, really community health assessment, address the true needs, and use that as a bridge to build a planning of a strategy that address those 40 to 65% of the population they serve if you're a community health, oriented hospital system. And in that way, deliver the right care, not be penalized by the feds, who are biggest payer now. 50% of their resource, their revenue is coming from the feds, and some of it from Medicaid. And therefore, I think, it fits perfectly in what we're saying here. There's nothing contradictory about what Joan is writing here. I just think that we don't have total response for all the questions at this point, but we may have a lot more as we finish and we have the largest sample size, 180 people as we expect, responding to those questions.
Thank you very much to both of our presenters and to our commentators today. We're almost ending our time frame, so I'll just draw your attention to the last slide on the screen, which is our upcoming webinars for April of 2015. Our next one will be April 1st from 12 to 1 Eastern Time on restructuring a state nutrition education and obesity prevention program. implications of a local health department model. And then on Wednesday, April 8th, also from 12 to 1 Eastern Time, we have Public Health Services Cost Studies, Tobacco Prevention, and Mandated Public Health Services. So again, we thank each of you for participating, and particularly our presenters and our commentators, and we hope to see you on our next webinar. Thank you.